Dr. Siddharth will be speaking about recent trends in management of retinopathy of prematurity.
Good afternoon, everyone. So, at the outset, I'd like to thank AIOS for giving me the opportunity to present this talk. Retinopathy of prematurity, as we know, is a vasoproliferative disorder which affects the preterm babies who are underweight, with low birth weight, and who are obviously born preterm. So we need to focus more on the babies who are under 2000 grams, because that is the RBSK guidelines we are following, because we need to cover most of the babies because of their increased survival and the NICU care that we are having these days. Their survival is increased. So there is increase in the incidence of ROP we are noting, and to be focused is the very extreme low birth weight babies less than 750 grams who need to be screened early at 2 to 3 weeks of age, because they are at more risk of developing aggressive ROP. There are various algorithms which are predicting ROP development based on the demographic profile of the babies, their gestational age, birth weight or sex, and even AI enabled tools are reasonably capable of predicting the ROP development. So these can be used by the pediatricians to refer babies to ophthalmologist. We are well aware of the zones and various stages of the ROP. To be focused here is the zone 1 and posterior zone 2, where if the ROP develops in this zone, it needs to be aggressively managed because it is sight threatening. So to just summarize, we have stage 1, where we have a demarcation between the vascular and the avascular retina. When this gains a height, it becomes a ridge. So this is a stage 2. Eventually there's a stimulus from this hypoxic retina, the increased VEGF load, which causes the retinal vessels to abnormal retinal vessels to grow into vitreous cavity, and that is the formation of the stage 3. Eventually there's a partial retinal detachment, and eventually the retina detaches. So it's stage 4 and stage 5. Once there is a dilatation and tortuosity of vessels at the posterior pole, this is the predictor of the aggressive ROP. Now this aggressive ROP is also noted in anterior zone 2. So that is the why the terminology is now changed from aggressive posterior ROP to aggressive ROP. And this is the disease that does not progress through the conventional stages of ROP and needs to be tackled early. So the management guidelines for ROP are based on the early treatment ROP cooperative group, where zone 1, any stage with plus disease needs to be treated, be it stage 1, 2 or 3. Zone 2, stage 2 and 3 with plus disease require treatment. All other can be followed up. And for the convenience, we have for management, we have type 1 and type 2 ROP. So zone 1, any stage with plus disease, or zone 2, stage 2 or 3 with plus disease is a type 1 ROP. It requires treatment. Type 2 can be observed. So the treatment of ROP, as we know, the pathogenesis lies with the hypoxic retina, which is stimulus for the VEGF. So we require anti-VEGFs, lasers or surgery. Now anti-VEGFs are the preferred treatment option for ROP, and these are predominantly used in aggressive type of ROP. This is the recent study, which was the survey which was conducted involving 54 ophthalmologists from 11 countries, and each of the ophthalmologists were routinely screening about 394 babies per year. So based on their response, these were from the developed and the developing countries. However, India was excluded, but based on their response, this is the preferred pattern which we are even following in India. So this is the preferred pattern. So most of the ophthalmologists for aggressive ROP, type 1 ROP in zone 1 and type 1 ROP in posterior zone 2 were using anti-VEGFs. Laser was used for the disease in anterior zone 2 or zone 3. Laser is a definitive treatment, but it is routinely being recommended and being preferred by ophthalmologists once the anti-VEGF has been given to treat the persistent avascular retina, or once the disease recurs. Mostly the ophthalmologist was not giving a repeat injection once the recurrence is noted after first dose of anti-VEGF. So preferred anti-VEGF being used by majority is bevacizumab in half the adult dose. So BEAT ROP study and Rainbow trial have given the evidence that anti-VEGFs can be used for ROP. Ranibizumab has been approved after the Rainbow trial for use of for its use in retinopathy of prematurity, and it's continues to be a off-label use. in other countries. DCGI approval has also been given for ranibizumab. So in our practice, we are using ranibizumab mostly because it is a one-dose vial which is available. Avastin has cost issues. There's a problem of dividing. The parents have to be convinced that the entire vial has to be used for single time. So they may not be convinced, but the efficacy of bevacizumab is much more as compared to ranibizumab. So the injection has to be given in the OT setting. We have to, usually a bilateral injection is given because the disease is mostly symmetrical, and the injections may have to be given in the ICU because it's the babies who cannot be transferred. It's not that we leave untreated, and sometimes the babies who are systemically more sick, anti-VEGFs do better than laser because the children, that's a painful procedure, it's a long procedure, they may not be able to handle, so anti-VEGFs are relatively safer. So as I discussed, most of the respondents were preferring bevacizumab, and aflibercept, only the 3 of the respondents out of 54. It has an advantage, it's a long duration of actions, yet there are limited studies for its use. So aflibercept, not a routinely recommended anti-VEGF. So bevacizumab is preferred in developing countries, as I mentioned the reasons, because of the cost, the recurrence, and the ease of administration, one dose vial available which can be divided in both the eyes. Ranibizumab is being used in developing countries. 0.2 milligram, we're using 0.25 milligram in 0.025 ml. So that dose does better than 0.1 milligram dose of ranibizumab. So this I have already discussed. So ROP occurs more frequently with ranibizumab treatment. So it was observed that about 40% of recurrence in anterior zone 2 was noted with ranibizumab. However, when bevacizumab was given, about 10% of the babies has recurrence in zone 2, and about 2 disc diameters of persistent avascular retina was observed in less than 10% of babies who were given bevacizumab. Aflibercept is still very limited use. There's increased popularity of anti-VEGF since 2019 because I discussed in unstable babies with unstable systemic conditions, anti-VEGFs are preferred, they are safer, they can be given under topical anesthesia, but the risk of endophthalmitis, so it is always better to be given in trained hands because you can have intralenticular injections, you can have RDs, so that is not to be taken lightly. So this is the table which I have referred from the study which has been published in 2024. So what we can see is the anti-VEGFs have been used commonly in aggressive ROP, in zone 1, in zone 2, type 1 ROP. So this is one of the preferred pattern from the clinicians. So babies, less than 20% of the infants who were being treated, 34% of the clinicians wanted to give them anti-VEGFs. However, we can see the number of anti-VEGFs being given is increasing, has increased considerably since the pandemic. So laser, as I told, it is used for disease which is in anterior zone 2 or zone 3, and it is used for babies who come with recurrence after first dose of anti-VEGF. So this is ultra wide field angiography which has now taken its importance in the diagnosis of ROP and to follow up. So this we can see that there is a persistent, there's a avascular retina in zone, you can see a demarcation line, and once given the anti-VEGF, the vascularization has progressed. So this gives, Optos gives a 200-degree view, unlike the RETCAM which gives 130-degree view. So this is underutilized but can be used in babies who have been given anti-VEGF. So we can see the avascular areas here, we can see the aggressive ROP and various neovascularization and the ischemic scapulin, the non-perfusion areas in the periphery. So point to be noted here is FFA can give a guide for targeted laser in babies with ROP who have been given anti-VEGF. So not to laser the entire avascular, but this is a limited availability, costly instrument to take the pictures in a flying baby position. So in our routine practice, if we feel there is a avascular retina after anti-VEGF at 10 to 14 weeks, it's better to go ahead with laser than to, because the follow-up may be a problem and the babies will grow older. So that I have already discussed. Stage 5, limited, many babies are not subjected to surgery when we have a closed funnel RD. So but we have seen that when there is a stage 4A ROP, lens sparing vitrectomy, the mobile visual acuity can be achieved in about 50 to 75% of cases. So all babies need not be operated. It's the decision of the treating ophthalmologist. And stage 5 babies, just to have maybe from hand motion to a finger counting vision, that can be achieved, but not all babies have to be operated. It's just from case to case basis. So anti-VEGFs, follow-up time frame about 55 to 60 weeks we have to continue follow-up, and there is no consensus on follow-up guidelines, but you can follow up these babies as long as 1 year, because recurrence has also been noted at 6 years in one of the cases. So long-term complications need to be taken care of. Myopia, this was a child who received ranibizumab, and she had about minus 12 diopters of refractive error. So it's not that the anti-VEGFs result in high myopia, it's the not just the lasers, the anti-VEGFs can also result in high myopia, though they're mostly causing a moderate myopia. But high myopia has also been noted. Squint has to be taken care of. Regressed ROP babies can also have myopia, squint and isometropia. So it's a long-term follow-up. Stereopsis is better in babies who have treated ROPs than the ones who are not treated. Neurodevelopment delay is not definitely proven with anti-VEGF, so they are relatively safer as on date. So at the end, I would just summarize that parent knowledge is important. Baseline refraction have to be done in all babies. They can have multiple systemic anomalies, so their hearing, neurodevelopmental assessment, and the neonatologist has to be kept in loop, because their weight gain is important, anemia control is important, because if it's not there, then the ROP won't regress. So the weight gain, anemia control has to go hand in hand with this. Thank you.
Thank you. A very elaborate discussion you have given. So just one question. Had there been any follow-up of anti-VEGF with the laser, long-term follow-up of visual acuity till now, or it is still ongoing, or we are not at a stage to say which will have a better visual gain?
What we have noted is it's a theoretical discussion, because the visual field defects are more common in babies who undergo confluent laser and who have a disease in zone 1. So if there is aggressive ROP, because all may not be giving anti-VEGFs. So if it's a zone 1 disease, laser is a definitive treatment. So people may be just going directly ahead with laser. So if there's a large area which is lasered, because anti-VEGF gives a time for the vessels to grow, and the limited retina has to be.
No, it's like we are still following up, and we don't
they're still
have
following,
the
because I have not
results,
come across any study
yes.
which is definitely giving the visual acuity quantification. So that I think has to be seen.
Yeah.
Yeah.
So maybe in the next few years we'll be coming up with it, because more we are going into anti-VEGFs and less are into the lasers now.
Yeah.
So what is actually having in the long term, 5 years down the line and 10
because
years?
2019 only the trend has come
thing.
up. Yeah, you're right. Thank you.
Any side effect have you encountered
No,
with?
no side effect. We have touchwood not seen any case of endophthalmitis, no lens injection, and plus disease immediately goes off in the next day. We can see the response is visible, but in about week to 10 days, it usually disappears. Thank you.
Thank you.